Hello, my name is Lucian Mirra. I'm one of the medical emergency educators at Life Support Learning Center. And the LSLC, along with our partners at Blue Ridge Poison Center, are happy to present this lecture on toxidrome and poisoning review for EMS providers. And while this lecture is mostly focused for EMS providers, it is completely applicable to anybody in an emergency setting, so applicable to both EMS providers as well as emergency department providers as well. Our standard disclaimer, this is for informational and educational purposes only. We obviously do not intend this to diagnose or treat any medical condition. And while this has been reviewed and input provided by our board certified toxicologists and toxicology fellows at the University of Virginia, you should always follow your local protocol when you're treating any patient. So our objective for this presentation, we're going to discuss the basic routes of exposure. We're going to understand how toxidromes can be used to categorize poisoning, and then we're going to review how to treat poisonings regarding different toxidromes. So first, when considering your poisoned patient and whether that patient is suffering from an intentional or an unintentional poisoning, we always want to first consider providing supportive care. No matter what the patient has ingested or has been subject to poisoning by, we always want to ensure that we maintain ABCs and do the basics of care for that patient. So this may include airway management and ventilatory assistance as well as oxygenation, keeping in mind that several of these toxidromes that we'll talk about today do cause patients to possibly need aggressive airway management such as intubation and or rapid sequence induction. And also keeping in mind that sometimes things like pulse oximetries can be a little bit misleading because your patient may have an adequate SpO2 but is unable to maintain or control their own airway. So always be aggressive and be thinking the next step in terms of what may be needed for your airway, the patient's airway. Also want to make sure we're supporting circulation and providing IV fluid for hypotension and shock management. Ensuring that we're providing EKG monitoring and appropriate ACLS care where applicable, and checking blood glucose measurements. So, four basic routes of exposures that the patient may encounter the poison by, and again, these can pretty much all be intentional or unintentional weight routes. First, absorption. This is contact through skin or mucous membrane. So, a patient, your farmer who accidentally has an organophosphate fertilizer spilled on them, that can absorb through the skin and thus cause poisoning. Similarly, through the skin, something like a fentanyl patch obviously is being absorbed, but also keeping in mind that things through mucous membranes is also considered an absorption. So a patient who snorts a drug, maybe it's a line of cocaine or whatever their drug of choice is, if they're snorting it, that is technically an absorption type poisoning. Ingestion, this is through the GI tract, and this is the primary route that we see unintentional poisonings, specifically of children, because they will get into liquids, especially the brightly colored liquids, pills that might look like candy. So the obvious reminder there, if you do have young children in your home, whether living in your home or visiting, that you're ensuring that any of those products that could be gotten into are kept either high up or locked away so they can't get into that. So this could be drinking something, this could be taking pills, any number of those things. Inhalation, so that would be breathing in the toxin. This could be a patient that is intentionally ingesting something through inhalation by smoking or huffing. Also keep in mind, especially for EMS providers that are called to the scene of a structure fire for a standby, keep in mind that those patients may experience some inhalation, especially of hydrogen cyanide, and may suffer from cyanide poisoning. People either pulled out of the structure or even firefighters. And lastly, injection, as the name would imply, this would be intravenous or intramuscular administration of a poison. So the example of this, the easy example, is a patient that is shooting up a drug directly into their vein. So what are these things that we're calling and referring to as toxidromes? So a little fun fact for you, the word toxidrome is a portmanteau of the word toxin and syndrome. So I'll give you a second to look at that and see where that word comes from. And what toxidromes are a constellation of signs and symptoms related to a specific class of poisoning. The idea behind a toxidrome is that instead of trying to memorize any number of different specific poisons, what toxidromes allow us to do are group these signs and symptoms together and group types of poisonings together, and that way we can provide a general guide for treatment. The thing to note with this, and while this presentation today will focus mostly on poisonings that fall into 6 different primary toxidromes, it's important to keep in mind that toxidromes are neither all inclusive nor all exclusive. So this means that there are definitely some poisons out there that don't fall into any of these classes that we talk about. And we'll also talk about things that may fall into multiple toxidromes. So while this is a good general guide for treatment, especially in the pre-hospital environment, keep in mind that this is not always going to be the case. So we're going to talk specifically about 6 toxidromes: the anticholinergics, the cholinergics, the hallucinogenics, the opioids, the sedative hypnotics, and the sympathomimetics. So we see this chart here, and it lists some examples of each, and we're going to go into each one of these 6 individually, so we're not going to spend too much time here. But the main thing to get out of this chart is that we can delineate the effects that each one of these toxidromes have on things like heart rate, respiratory rate, temperature, pupils, and bowels. And specifically bowels, we're thinking of bowel sounds. So we'll go through each one of these, and you can even see as we're starting here, some things don't even fit well into one category, and clearly there are going to be things that you're going to think about during this presentation and that you'll not notice as an example. So keeping in mind, again, toxidromes are not all inclusive or exclusive, but do provide us a good starting point, especially in the pre-hospital environment, to manage our patients. So another chart here for you to use. This one actually uses pupil size as a first determinant, and this is more of a flowchart type, so operating from pupil size to temperature and bowel sounds to allow us to differentiate between different toxidromes. So now we're going to get into each one of the toxidromes, and we're going to talk about their mechanism, some examples of each, and how they present, and some treatments that we want to think about pre-hospitally and in the emergency care settings. So the first toxidrome we'll talk about are the anticholinergics. The mechanism of the anticholinergic is that it blocks the muscarinic receptors, uh, the muscarinic acetylcholine receptors, and this inhibits a parasympathetic response. If you'll recall, acetylcholine is a primary neurotransmitter of the parasympathetic nervous system. So if you block the receptors to which acetylcholine binds, then you're going to inhibit the parasympathetic response. So while this doesn't necessarily provide a sympathetic response, a lot of what we'll see are somewhat similar to a sympathetic type response, but really what we're doing is we're taking away the parasympathetic. So instead of stimulating the sympathetic, we are merely not allowing the parasympathetic to be able to function. So what does this mean, and how do these patients present? This is not a mnemonic per se, but almost a little bit of almost a nursery rhyme for us, a memory aid for us to be able to identify our anticholinergic patients. And that is that they're dry as a bone, blind as a bat, red as a beet, hot as a hare, and mad as a hatter. So why are they each one of these things? So we'll start with dry as a bone. So you'll also notice that they're dry as a bone and they're hot as a hair. So characteristically, and actually very characteristically of anticholinergic poisonings, these patients typically present very hot. So they feel very hot to the touch, but they're very characteristically dry, so that they are not diaphoretic. The reason for this is that the sweat glands are modulated by the muscarinic receptors, and thus in an anticholinergic poisoning are rendered non-functional. Blind as a bat, this is really secondary to mydriasis, and ciliary muscle paralysis. So these patients will typically present with very dilated pupils, and they're unable, the ciliary muscles are what actually controls pupillary response. So they're unable to constrict their pupil to light. So if you think about, you come out of a very dark room, maybe you're in a movie theater, and you come out into the sunlight immediately, takes a couple seconds for your eyes to adjust. In those couple seconds, you're unable to see anything. Just think about that, but your eyes are unable to adjust. Or you've come out of the eye doctor where your pupils have been dilated, and if you've ever had that happen, then you'll recall that feeling. So just think about that, but amplified, and that's what these patients are experiencing. Red as a beet, there is a decrease in precapillary tone, which causes flushing to the skin. Hot as a hair. These patients, again, we've already talked about their inability to sweat, and typically they are also very agitated, and they're almost. And you see the next one again, mad as a hatter. They're almost very characteristically agitated, and the characteristic agitated behavior that you may see is actually kind of a picking behavior, very like a phantom, like they're almost reaching out for something that's not there, and that is extraordinarily characteristic for an anticholinergic poisoning. They may also be suffering from ataxia, stupor, um, may have vivid hallucinations. That also may be coupled with lucid intervals. So think about that when you have a patient who maybe presents initially lucid and then becomes agitated or suffers from this odd picking, phantom picking type behavior. And also think about that as well. Some examples of anticholinergics. So, one of the drugs that we give in the pre-hospital and emergency setting is actually an anticholinergic if given in large enough doses, and that's diphenhydramine or our good friend Benadryl. And another one that we give in the pre-hospital environment is atropine. So, both of these are anticholinergics if given in large enough doses. The tricyclic antidepressants, so not as common anymore in terms of treating as depression. Amitriptyline or Elavil is one that is still somewhat sometimes prescribed. These actually antagonize the H1 and H2 receptors as well as the muscarinic receptors, so that's why they fall into the anticholinergic class. Some mushrooms and plants fall into this class as well. Characteristically, Jimson weed is one that is an anticholinergic that falls into this class. I don't believe we have that. But any of the plants in the nightshades family actually fall into the anticholinergic class. So the treatment for anticholinergic poisoning, obviously supportive and calming care, especially if they are agitated. Supportive care will again refer back to one of those early slides. So that's doing everything, ensuring that we're maintaining airway, breathing, circulatory status, and doing good thorough assessments on our patients. Also, for these patients, considering IV fluids for rehydration because, again, they are unable to sweat and typically very hot. So, providing some IV fluids for them may not be a bad idea. Specifically, if the patient does have a TCA, tricyclic antidepressant overdose, we really want to make sure they're on the cardiac monitor and we're watching specifically for QRS widening. If they do have QRS widening, and this QRS widening is due to the blockage of the sodium membrane channels, which slows membrane depolarization. So if they do have that QRS widening, we're going to think about sodium bicarbonate. This may both reverse the sodium channel blockade as well as creating a less acidic environment. And in a less acidic environment, you actually get more protein binding of drug, which would thus decrease the bioavailability of the drug. So that would be specifically just for tricyclic antidepressants. We'd be thinking about sodium bicarbonate. Our next toxidrome are our cholinergics. As you can imagine, this is the opposite of anticholinergics, as the names would imply. And the mechanism here is that we actually get an increase in acetylcholine by inhibiting this enzyme called acetylcholinesterase. Acetylcholinesterase really just hydrolyzes or breaks down acetylcholine into choline and acetic acid. So, what happens when a patient has a cholinergic poisoning is that this enzyme that breaks down acetylcholine is inhibited. And when this happens, the organophosphate and any of the other cholinergics actually bind at the active site of this enzyme, which inhibits acetylcholine from being able to bind to that and thus be broken down. So the problem here then is you have an unmodulated, unmediated parasympathetic response. So these patients are very characteristically presenting with this phenomenon that we call, or that we use the mnemonic dumbbells or sludgeum. and these are listed here in the charts on the slide. However, the really big factor, the predominant factor leading to death in cholinergic poisoning is actually respiratory, which is secondary to bronchospasm and bronchorrhea. So just excess sputum production, they almost experience a pulmonary edema-like phenomenon where they're almost really internally drowning. We can also see a lot of seizures in these patients, again, and that's due to the excess acetylcholine that they have. Some examples of these, the organophosphate pesticides. A lot of these, like parathion, have been outlawed and really shouldn't be used anymore. But you do see them. You do see some other versions out there. Some nerve agents such as sarin. So the nerve gas attack back in Tokyo in the 1990s was the sarin gas attack. The treatment for cholinergic poisoning, again, supportive care. These patients typically do need very aggressive airway management and may need intubation and or suctioning or positive pressure ventilation. We want to think about if we have the Mark 1 kits or Mark 2 kits available. Those are a mix of atropine and pralidoxamine, and those are very effective. If you don't have the kits, atropine by itself is effective, and this is going to require very high doses of atropine. And what the atropine does, again, if we recall from from the anticholinergics, atropine is a muscarinic receptor antagonist, so it really reverses the issues caused by most of the cholinergics. And pralidoxamine reactivates acetylcholinesterase. You also may, if the patient is seizing, may want to consider giving them benzodiazepines to stop that seizure. Our next class, our next toxidrome is hallucinogenics. The mechanism of hallucinogenics kind of varies by the psychoactive agent. So, that being said, the presentation kind of varies, but generally these patients are very disconnected or spaced out from reality. As the name would imply, they typically are experiencing hallucinations. These can be very vivid, these can be very lifelike, these can sometimes be very scary for the patient. So some examples of hallucinogenics, lysergic acid diethylamide or LSD, which is a chemical that was synthesized, a strong psychedelic. This is known as acid in the kind of inner circles of the drug world. Um, DMT is another one that is a psychedelic, again a manufactured chemical. Then you have your dissociative agents. Ketamine, again, here comes another drug that we give in the pre-hospital and in-hospital environment. And PCP or phenylcyclidine, a strong dissociative agent that is a drug of abuse. These patients typically don't require too much in the way of emergency care other than supportive care. They oftentimes will be very disoriented. Just experience in taking care of patients that are on some of these. I've had some of these patients think that the ambulance is like a spaceship, and these people are just totally spaced out of any sort of reality. So constant reorientation, calming the patient. If they're truly agitated, we can consider a benzodiazepine to control their agitation. So our next toxidrome that we'll talk about is opioid toxidrome. And I wanted to preface the opioid by acknowledging the opioid crisis that we have in the United States. Um, Many deaths each year, and this is increasing nearly every year where we see opioid deaths. And just some headlines picked out for the past couple years. 174 overdoses in 6 days in Cincinnati, 28 overdoses in 4 hours, and that was in Huntington, West Virginia. Even close to home, 2 heroin overdoses in a day up in Madison County. So truly, it's a pandemic of its own, and you see here the darker shades are higher opioid overdose deaths. Um, Down here, and you look at Central Virginia, we're actually, not the worst off. However, you can really see in some of the areas that may refer patients to us specifically West Virginia, Kentucky, Southwest Virginia, places like that do have a higher incidence of opioid deaths. And this is back in 2015, so this data obviously may have changed. So the opioids themselves, they activate opioid receptors. Two primary opioid receptors that are activated by opioids are the mu receptors and the kappa receptors. The mu receptors are what causes your respiratory depression. They also cause euphoria and analgesia. Obviously, the analgesia is the prescribed sort of purpose of opioids. Kappa receptors also cause analgesia, can cause some dissociation and sedation as well. So, as we can think about and as is implied by the mechanism, we would expect these patients to have a decreased level of consciousness. They can have respiratory depression and sedation. So examples: fentanyl, morphine, again, both drugs that we use pre-hospital and in the hospital environment. Heroin and other things like codeine, oxycodone, hydrocodone, or Vicodin. Any of those drugs are all in this class of this toxidrome. So our treatment for an opioid overdose: support the ABCs of the patient. This is key, especially in opioids, because they may be experiencing respiratory depression. They may not be able to maintain their airway. These are the patients that you get there, and they're breathing 4 times a minute, and other characteristic presentations. Obviously, pinpoint pupils, and the other kind of anecdotal one is from having run EMS in a city where we did see a lot of opioid overdoses. For some reason, the ice in the groin is kind of a urban legend or urban myth, if you will, that for some reason people think that putting ice in the groin will reverse an opioid overdose. So that was actually a very good clue for us when we get on the scene of an unresponsive patient and there's ice or frozen peas in somebody's groin. It was like, okay, I know what this is before we've even done much of an assessment. But really looking at naloxone specifically if they have respiratory depression. So if they are breathing again, 4 times a minute or something like that, we want to get that Narcan, that naloxone on board as soon as possible. And whether that's intranasal, intramuscular, or intravenous, whatever the fastest route to get that on board is key. Our next toxidrome are the sedative hypnotics. These increase the activity of GABA, which is gamma aminobutyric acid. And really, what that does is GABA itself reduces neuronal excitability. So, this just basically causes sedation. So, with an increase in GABA, we see a reduction in this excitability, and thus we see a sedative factor in our patients. So, obviously, these patients are going to present very sedate, sleepy, tired, difficult to rouse. They may have amnesia as well. So some examples of these, and again, almost every one of these classes of drugs we find, or every one of these toxidromes, we find drugs that we give in the pre-hospital environment. So all of our benzodiazepines fall into this sedative hypnotic category. The anesthetics, so things like propofol, fall into this. Also, things like cannabis, so tetrahydrocannabinol, cannabinol or THC, the active ingredient in marijuana, falls into this. Gamma hydroxybutanoic acid, or GHB, which is commonly referred to as the date rape drug, falls into this class, as well as our very common ethyl alcohol or ethanol. So alcohol falls into this as well. These patients typically just need supportive care. There's really not too much in the way of reversal agents. There is a reversal for benzodiazepines, but we don't really use that in the pre-hospital environment that much. What we do have to be careful about, and what we do see with these, however, is the issue of polypharmacy. And a lot of times, what we'll see is a patient that has taken something like Xanax and mixed it with alcohol. So when you mix these two, obviously both are sedative hypnotics. You have a synergistic effect going on, and thus you cause even more sedation. So, again, these are the patients that also may need aggressive airway management depending on the amount of uh, drug they have in their system and how it's affecting their ability to maintain their own airway. Sympathomimetics, so these mimic sympathetic response. They activate postsynaptic receptors, which blocks the reuptake of things like monoamine oxidase, or they just simply themselves stimulate the release of catecholamines. So, by blocking the reuptake of MAO, they cause a sympathetic response or cause an uninhibited sympathetic nervous system response. And again, the release of catecholamines would be a direct sympathetic response. So these patients present very tachycardic, very excited. You may have agitation in these patients. They're typically hot but characteristically diaphoretic because while they have a lot of sympathetic response, we have not blocked, unless there is polypharmacy going on with an anticholinergic, we have not blocked the parasympathetic response. So while they are hot, they are also typically very diaphoretic. You may also see very dilated pupils with this as well. Examples of this: cocaine, methamphetamine, MDMA, bath salts can fall into this category. This is a synthetic drug. The treatment for the sympathomimetic supportive care may think about some passive cooling if the patient's hyperthermic. And if the patient is experiencing agitated delirium, then we want to consider benzodiazepines, as well as considering benzodiazepines if the patient is seizing. So just a couple quick notes on Molly or MDMA. So going back here, MDMA is 3,4-methylene dioxymethamphetamine, and so this is a very socially used drug. And the reason why I'm doing a little bit of a focus on this is because it is one of the drugs that is most highly used by college age students. Um, it is typically seen in raves, which are kind of dance parties, also very heavily used in festival type concerts. The electronic dance music or EDM scene, very high incidence of MDMA use. MDMA is known as Molly, is one of the main street names for it. So we see here a couple of headlines of, and these are all music festival headlines, which is not something that we have here in the Charlottesville directly, but things, in the outlying counties, we do have obviously some music festivals that go on that do see some MDMA use. Hitting a little bit closer to home, Shelley Goldsmith was a UVA Eccles scholar who was on a weekend trip in Washington, D.C., had never used drugs in her life. Molly, by the way, is just seen by a lot of college students as being a very safe drug. It's something that they take on the weekends. It's a derivative of ecstasy. Ecstasy was developed actually as a drug used by psychiatrists. It was used for marriage counseling and PTSD following the Vietnam War. So it in theory is supposed to make you very happy, very outgoing, appreciative of touch, things like that. The problem is, however, um, as with any drug that you get, the quality of it is very questionable, and it has some pretty devastating side effects that most people aren't aware of. So again, thinking about specifically some things with MDMA, typically again we see some polypharmacy going on with this. So people who are using MDMA and whether it is at a festival or an EDM rave or at a club or something like that, typically they're consuming alcohol. A lot of times there's other drugs such as marijuana or cocaine around, and we actually see a large use of caffeine with this as well. These people want the energy. There's a lot of dancing going on, so it is not uncommon to see these patients have had, a couple things like Red Bull or things like that as well. So what you end up getting is sympathomimetics, sometimes two or three sympathomimetics if you stack MDMA with cocaine with a Red Bull or coffee. So you have several sympathomimetics plus a hot environment. So they're dancing, they're at a club, or at a summer outdoor concert venue, and you end up getting a very hyperthermic patient. You also wind up sometimes with a very hyponatremic patient, and this causes seizures that are refractory to benzodiazepines. So just something to think about as providers working in a college area, as well as an area that does see some outdoor music festivals, to be kind of on the lookout for the use of MDMA and be able to recognize and treat it. So lastly, with any of these, and with any poisoning, whether they fall into a toxidrome or not, remember that the Blue Ridge Poison Center is your resource for poisonings. The Blue Ridge Poison Center is located here at UVA, and it's a regional resource for any toxicology question. Feel free to call the Blue Ridge Poison Center even with a non-emergent question. So you're curious about something, definitely they love to take those calls as well. The Poison Center is staffed by certified specialists in poison information. They are 24/7, 365, able to answer your calls, and they do close to 30,000 calls a year. So a lot of calls coming in, and you can see there on the map all of the counties in white are the area that refers to Blue Ridge Poison Center. They also have access to our board certified toxicologists 24/7. So if it is anything super complicated, they can involve our toxicologists such as Dr. Holstag, uh, Dr. Borek, Dr. Charlton, and those. So 1-800-222-1222 is the actual national number for poison centers. So that will get you to the closest one. And you see there the last thing on this slide, the top substances used or referred to the poison center. Analgesics, typically, which fall into the opioid, is the number one of all ages substance presenting. You also see sedative hypnotics on there, alcohol, antihistamines, which typically fall into the anticholinergic class, stimulants such as sympathomimetics. So most all of these toxidromes fall somewhere on the top substances that are referred to calls by the Poison Center. So please, 24 hours a day, whenever you need that resource, give them a call. They're a great resource for our EMS and our emergency department friends. So special thanks to Doctors Holstag and Kapotic with the Blue Ridge Poison Center and Division of Medical Toxicology for providing some insight and co-authoring this lecture. And if you have any questions, feel free to send me an email. Otherwise, stay safe, and we'll see you out there on the streets.